Well, good morning, everyone. I know we are running on a tight time frame, so I need to get started on time to be respectful of everyone's schedules here today. My name is Michele Strasz. I'm the Executive Director of the School Community Health Alliance of Michigan, and I'm happy to welcome you to No SBHC Left Behind. If you weren't expecting to be in that session, welcome anyways. We're glad to have you. We're going to talk about the importance of billing for your centers and for the work that we all do collectively. But we're going to get more specific and talk about the transition from ICD 9 to ICD 10 and help calm your fears. So I'm joined here by two of my colleagues who I'm going to let introduce themselves to you, and then we'll get started. Joy?
I'm Joy Twesigye. I'm a program manager with Programs and Professional Services in NASBHC, and so I'm thankful that you are all here today, and hopefully for multiple days for our conference. We are thrilled to have you here, and I hope that your fears are allayed with the transition to ICD 9 to ICD 10. I'd also like to say that we encourage you, we're trying to encourage people to use social media, and so we've got some tweetables that are in the PowerPoint, so we won't be offended if you whip out your phones and you start doing it. We've tried to make it as easy as possible for you, so we've got some slides with some tweets prepared.
I'm Theresa Reid. I'm the billing administrator for Integrated Health Services. We manage the school-based health centers in East Hartford, Connecticut.
Okay. Good. And I need to take care of a couple housekeeping items. First of all, we have no relationships to disclose this morning. As Joy mentioned, we will be tweeting during the session, and this is a simulcast session. So our colleagues around the country, including my staff, so hello staff, are watching this session today. And we look forward to your participation. And if you have a question or a comment during the session, we ask that you please come to the center aisle and come to the microphones because we want the audience that's watching on the simulcast to be able to hear everything that we are discussing. So having said that, let me scroll through this pretty quickly here. One of the things that we wanted to talk about today was the importance of billing and the power of billing. You heard yesterday in the plenary session from our keynote speaker about the importance of the census data. Well, this, quite honestly, is kind of like our census data. It's the power to tell the story about the students that we serve. It's the power to talk about the services that we provide. It's the power to talk about the potential capacity that we bring to the quality of health care in our country for our children and youth. So to start us off today, we're going to kick it right off with something interactive. If you could just think for a moment, why is billing so important to your SBHC? And Joy's going to record that. If you can raise your hand for this one, and then we'll put them on the screen so that our audience can see this. So, yes, sir. Survival, number one. Anyone else? Documentation of services, great. Kate in the back.
To demonstrate credibility in that we are playing in the game and everybody has to play it.
Okay, to demonstrate credibility that we are playing in the game for a good cause. Okay, yes?
To increase funding.
To increase funding. Anything else? Okay, well, we're going to jump through. Revenue, we did mention that. It's both for our survival but also for our ability to function. Quality, we want to be able to document that we are providing quality services, and then where we need to make some improvements, we have the information to be able to either develop training and professional development for our staff or look at some of the policy issues that might be necessary to change. Obviously, to drive policy change, and maybe policy change in your local center with your sponsoring organization. It may be policy change at the state level. I do a lot of work related to that within our organization. And it may be ultimately policy change at the federal level as we talk about authorization of funding for school-based health centers that was included in the Affordable Care Act. we need to be able to have good data to justify our ask at the federal level for authorizing funding. Reporting to funders. Obviously, we all have varieties of funders, whether they are our fiduciary agency or a federal entity or a private foundation. So we need to have that data to report to funders, that we are doing what we said we would do. Patient tracking. If you were in the session previously, there was a lot of conversation about student registries and tracking our student outcomes. Obviously, this is another important step that we need to include. How many of you are already utilizing an EHR in your school-based health centers? Okay, quite a few of you. And how many of you are in process? Okay, good, most of you. So you're beginning to understand the impact of this more and more every day, and that's a big part of what we will be talking about as we move forward in this session. So our first tweet for the day, if any of you are tweeting along with us, feel free to say, perspective and fear can get in the way of change. Bill anyway. #SBHC. So that's my segue to turn it over to Joy.
Thank you, Michele. Oh. Okay. All right. So we didn't ask at the beginning, at least I don't think, how many of you currently bill? Great. And then how many of you are sort of on the fence?
We're trying.
It's okay. Normally those people are sending me emails and phone calls. There's plenty of people who are on the fence in terms of billing. And so, we just talked about that billing is important for a host of reasons, and a lot of us come to that sort of intersection in our career about we want to deliver these healthcare services that we think are really important, and then we also like to keep the lights on. We like to get paid. We like for you to get paid. We want to provide extra services for the kids in terms of, if it's transportation or whatever of those other things that we want to do. And so this is one of the ways in which we can facilitate that. In the previous session, it was mentioned that billing will not solve all of your problems, but it is a way. You're already doing the work, so you might as well, get paid for it. And so we just want to acknowledge that it can be frustrating at times, and your perspective and fear can get in the way, and we just want to encourage you to bill, because you have to, practice makes perfect, right? So you just have to go out and do it. So we want to encourage you to bill anyway. If you're nervous about the transition between ICD-9 and ICD-10, just go ahead and jump into it and bill anyway, because that's the only way that you can learn how to do it. So we want to tell you a little story about Kodak. So Kodak is, basically it's about a 130-year-old company that, filed for bankruptcy in January. And they got down to this path because they really were not capitalizing on the basic services that they provide in a modern way. And why, you might ask? And really a lot of economists, and a lot of, armchair bloggers have decided it's because they passed on picking up the digital camera, which is a little terrible, because in 1975, their engineers, created the core technology for the digital camera. So they already owned the technology, and they were just like, what, we've got 100 years of successful, services. The executives were like, we have been producing chemicals and paper and film for 100 years. We don't need to really embark on anything new. We're all right, we've done it, it's okay. Until it wasn't okay. And then, because their competitors picked it up, and then they basically spent all of the 1990s trying to catch up, and obviously it didn't work. So that's fine in a sense for Kodak. I can go to a different company and buy my camera and buy my film. I can go to a different company and use their photograph shared site, but the children that you serve, it's a little bit more difficult for them to go and find another access point to care, which is why you're all trying to deliver the services that you're trying to deliver.
Good morning. Well, now that Michele and Joy have given us a new perspective and excited us about billing, we're all ready for ICD-10, right? As most of you know, ICD-10 will not go into effect until October 1st, 2014. And that's over 2 years away. So why are we here this morning talking about ICD-10? Well, we still like to address some of the concerns and fears you might have regarding the new ICD-10 coding system. And to also give you a brief overview of what the ICD-10 coding system is going to consist of. It's going to be a brief overview because there's just not enough time to go into it in depth at this session. And also, with the brief overview, the majority of our presentation is going to be on the, a larger part of the presentation will be on the transitional concepts that you can use whether you're transitioning to EHRs or maybe creating a new billing system within your organization. They are really good, helpful tools, so we're going to continue to do that. And lastly, because we had started the process of creating this presentation before the announcement that ICD-10 was going to be postponed until 2014. And I know for me, there was no going back to the drawing board for this presentation. So we're going to move ahead. So to start off, we're going to address some of the fears that you might have. It's going to be too complicated. It's just going to be too complicated for me to comprehend. Right now, ICD-9 has 13,000 diagnosis codes. Of those 13,000 diagnoses that are listed, how many do you actually see on a regular basis in your health centers? I'm guessing a very small percentage of those codes are used. So in actuality, there can be an unlimited number of codes in ICD-10, and we are still going to just use a very small portion of those codes. Just for a quick show of hands here, how many are treating students with cardiovascular disease at your sites? Or neoplasms? Traumatic brain injuries? Okay, there's a small percentage, but very few. The majority of our coding is going to be straightforward medical billing, so we're not going to get really into the more complicated, in-depth procedures or diagnoses that ICD-10. We're still going to be coding a basic, straightforward medical coding that we've been coding. We'd also like you to keep in mind that you're not alone, that there is help out there, especially on the internet these days. We've listed a couple of the websites that you can go to for help in free training and information on, more in-depth information on ICD-10. And also, there are sites that will help you, walk you through coding those most common conditions that you'll see at your health centers. It's a good practice to visit these websites and then kind of put them into practice of coding what you are normally doing now. Okay, another concern, documentation, documentation, documentation. Documentation is going to be a significant part of ICD-10, but that doesn't necessarily mean that more documentation is going to be required of you. What will be required is a more detailed documentation. For example, say a student presents with abdominal pain. Right now you can probably slide through and just list the diagnosis in the chart as abdominal pain or stomach ache. Well, with ICD-10, you're going to have to be more specific as to where that pain is located. Is it in the upper right quadrant or the lower left quadrant? But if you're using an ONC certified EHR, which some of you probably are already doing, you already have the capacity to provide that required documentation. And if you haven't transitioned to an EHR, then the documentation that you're going to need is basically just a little bit more detailed than what you should really already be documenting for risk management purposes. Another fear is how it's going to impact your cash flow, the rejected claims. And the reality is we all will experience rejected claims, especially through the learning curve for both you and the insurance carriers. So, and we have rejected claims now and we deal with them. So with the rejected claims because of this transition, we will all still deal with them and survive. But again, the documentation and the communication with your payers should minimize any interruption in your cash flows. Now I wanted to just take a few minutes. As I said, this is going to be a light overview of ICD-10. I wanted to just familiarize you with some of the similarities with ICD-9 between ICD-10 and some of the changes. The similarities, ICD-9 and ICD-10, they will both have the alpha listing and the cross-reference. And in the cross-reference, you're still going to see the instructional notes as to whether or not a diagnosis code can be a primary diagnosis, whether or not a diagnosis or a symptom is included in the particular diagnosis code, and also how many digits you would need to correctly code a certain diagnosis. Some of the changes, and again, just some of the changes, is ICD-9, as I said, had 13,000 diagnosis codes, where ICD-10 will have 68,000 diagnosis codes. So you can see what the documentation, the detailed documentation is going to do, how important that really is. ICD-9, you can code up to 5 digits. They may require you to code up to 5 digits, whereas in ICD-10, you could be required to code up to 7 digits. And in that 7 digits, you can have X's for free spaces, because they have built in an expansion. You know, just in case they do change code, they don't have to go through the whole system. In ICD-9, the V and E codes were the only alphanumeric codes. And in ICD-10, all the codes, as you'll see, will be alphanumeric codes. No school-based health center left behind. ICD-10 or bust. Who was in your zoo? Here's where those transitional concepts that I mentioned earlier come into play. They are used not only for ICD-10 transitions, but any major transitions that you want to make within your organization. You need to make a list, or at least think about, who are the decision makers? Who are the people that know your computer's capabilities? Are you sponsored by a hospital, a community health center, maybe the school system, or like I am, I work for a nonprofit organization? So you need to know, do you use the hospital's or the school's IT department or their server or software? Or do you contract with an outside vendor? Whatever your particular situation is, you need to make a list of the people that will need to be involved in the planning and decision making and the transition planning and implementation. And once you've made that list, or at least thought about who needs to be included on that list, you need to make a to-do list. And these are just some of the ideas that should be on your to-do list. And we'll go through them. The first one is to assign tasks. Make a list of the team players, what jobs they will be responsible for completing, and a time frame in which those jobs need to be completed. This is important for 2 reasons. One is you don't want to waste time duplicating efforts. You don't want 2 people working on the same issue. And another reason that you really want to make a matrix or some sort of a schedule is because you don't want to miss anything. Everything is important and you don't want any surprises. So it's just a good way of keeping on track. And another suggestion would be to hold regular scheduled meetings to keep everyone up to date on where you stand with the transition. We are in the process of transitioning to EHRs, and we have been having weekly meetings for months. And these weekly meetings have made available to us the opportunity to tackle any issues that came up at the moment instead of waiting before they became an even bigger issue. Do an assessment. Does your current software need updating to accommodate ICD-9 and ICD-10 simultaneously? Talk with your HIT or the school's IT department. It's very important because you will still be required to code any diagnosis prior to October 1st, 2014 with the ICD-9 coding system. And then any services after October 1st with the ICD-10 coding system. So you could possibly be working within both. Yes.
Can you move over to the mic? Thank you.
I know in the past they've said that we could start using 10, but that what you just said is we cannot until
Well,
the 14th.
you need to talk with your insurance carriers, or who you're submitting claims to. They might not be accepting those claims yet.
Right.
So, and which staff members will need additional training? The transition to ICD-10 might not affect every staff member at your centers, so you really want to think about who needs to be trained. If there are several people that need to be trained, you might want to think about sending training to one or two people and having them come back and train the rest of the staff. Touch bases with your insurance carriers. Will the new codes have any effect on your reimbursement and contracts? Will they be requiring anything extra for you to do or to submit that you want to be prepared for? You really don't want surprises, and you don't want rejected claims. So just keeping the communication going and being prepared is just a good idea. Plan ahead. Budget for, and I want to stress this, temporary additional costs for software updates and training staff. Find out where you could obtain any needed staff training. Again, I would recommend the websites that we had just put up on the other slide. They really will be very beneficial to you. And I'm sure the closer we get to October 1st in 2014, there will be much more information out there for you. Implement the requirement for more detailed documentation now. Anytime you can gradually make a transition, it's less stressful. Let's face it, it just is. So if there's anything that you know of that you can do now to prepare for the transition, go ahead and implement that. Determine if or how your workflow will be affected, and if needed, develop a new workflow. Practice coding with the ICD-10 system. It's out there. There are free training on the websites and a lot of information. So get that, read it, absorb it, and practice with it so that you are comfortable with it when you finally have to convert over to the ICD-10 coding system. I wouldn't wait. It's actually fun to just try to see if you can do it and get it right.
Fun.
Yeah. Okay, I'm in billing, you have a sense of humor. Okay. So right now we'd like to hear from you. What have been your experiences? What have you thought about, or have you thought about the impact that the ICD-10 transition is going to make on your health centers, and or a transition to the ERs, the EHRs? We can all benefit from you sharing your experiences, so we'd like to open the floor to anyone.
We need a brave soul. Why don't we ask how many of you are directly responsible doing the billing and coding for your center? So only a couple of in the room. Okay. How many of you are the administrators who are overseeing the process to get this underway? Okay. I'm not sure what the rest of you are. Can somebody tell us what your experience is?
If you work with a hospital, then the hospital does all the billing and coding.
Okay.
For us, we just send everything in. My question is
I'm sorry, can you come to the mic?
It hurt my knee.
If they weren't taped down, I'd bring it to you. I apologize.
Do you know if there's going to be like an app or something that our providers and their individual clinics will be able to put on their Blackberries or their iPads or something that will allow them? Because with our EHR, I know it has a standardized. We have a kind of an odd one. It's called CPSI, and we have the MPEMR, and it has a set of codes enlisted into it that will be adjusted based on the ICD-10. The problem is there's no possible way to add 68,000 codes to this preset billing form. So we do have the ability to add in the codes if they've done something that isn't in the 35 or 40 listed typical codes. So the question then becomes, without them having to overload the coding girls that we have, our sweet little coding girls, the 4 of them who do everything for the whole hospital and all 25 outlying clinics, is there going to be an app that will be easy for the providers in the clinics to be able to click and put in their info, and it will spit out for them what code they should use to add to that billing? That would be really cool. I'm just throwing it out there.
I'm sure that today with
entrepreneurial
technology
opportunity.
that is going to be the case. If not, we could work together, maybe make some money.
Right there, that's awesome.
Yeah.
There's already websites out there that I've already played with. There's the translators.
Yes.
Right. I think that the translators exist because I've used those, but I don't know if there is like an app where you can input that clinical information and then it gives you an answer. So I don't know.
If anyone is listening to this presentation today, I'm sure minds are going now to
Yes.
help you out with that.
I've got it down.
Yes. Me too.
Yeah.
Yes.
And again, the closer we get to the implementation date, I'm sure there is going to be a lot out there. And turn it over to you.
Sure.
Okay, it's time for a quick commercial break. We need to thank the Kresge Foundation for supporting the development of this workshop for this conference here today. A couple of years ago, our organization, the School Community Health Alliance, which operates the Alliance Practice and Data Management Services, worked with NASBHC to develop a grant proposal to the Kresge Foundation to help develop a national billing and reporting network across the country. This was before EHR really hit the fan. It's before we really started to think about ICD-10. And as a result of our conversations amongst various partners across the country, we decided we needed to take probably a more elementary stopping point and educate people, first of all, on why you need to be moving into EHR. And why you need to be doing billing. And to the extent that you can have your EHR and your billing integrated, we've been encouraging people to move in that direction. So we have been partnering with 4 other states over the last year and a half: Oregon, California, North Carolina, and New Orleans. I misspoke. It's actually 3 states and one region, New Orleans. To sort of pilot some of this and to provide some more direct technical assistance to the centers in those states who are engaging in development of EHR and integration with billing, and then obviously moving towards ICD-10, but also thinking about the importance of third-party commercial billing and how do we participate in the creation of accountable care organizations in our states. Many of your states are way ahead of Michigan right now in the implementation of healthcare reform. So I'm actually learning from, my peers and colleagues in other states about how to be positioning ourselves as we get started. So we are a learning community, and we are sharing some of what we are learning with you here today with the other state associations. So my commercial message is twofold. One, my organization, the School Community Health Alliance, can provide some technical assistance for you if you are interested in contracting with us regarding billing, regarding credentialing, regarding EHR. We also have done a lot of customized reporting and are thinking through very, very proactively about how do we integrate this ICD-10 into our reports that we do in Michigan, and also with the state of Delaware, who we have a contract with. But I also encourage you to be working with your state associations. If you have a need, if you have a question, they are a wonderful resource to you, and many of them have been developing the capacity to provide you with support around billing EHR issues as well. So we're working together to help develop this network, this National Billing and Data Network across the country, in thanks and in partnership with the Kresge Foundation. So I'm going to turn it back over to Joy.
Okay. So I became part of the work because I got to head up this clinical work group that was part of the National Billing and Reporting Project. And so I got to wrangle the experts across the country, about school-based health center billing, data reporting, and quality experts. And we really focused on 4 things. So we're working on creating a school-based health center data set. And so, when Theresa mentioned that, there could be 9 million codes, but we're really only using a fraction of those, the work that Michele and her colleagues had done, they'd already kind of created a data set, based on sort of their data mining experience, in Michigan and in Delaware. And so then what we did was sort of built upon that and, got feedback of really across the country, what are we generally doing in sort of volume that's representative of the codes. So, really in code form, it's representing what we're doing across the country. And then we also created a crosswalk between the B codes and what will be the Z codes in ICD-10. So we created this crosswalk, and I'll talk about it a little bit more because we want to encourage people to be using these V and Z codes in order to better tell our story. And that's ready to go, and we're going to be posting that on NASBHC's website, for you to download. And then we also spent a lot of time debating that we wanted to document the barriers to reimbursement to school-based health centers because they're very different. And so across the country, depending on how Medicaid is organized in your state and all of these different things. And so we are still sort of vetting a document that we will share that, and right now it's organized where we talk about the barriers at the family level, and then from the building to the sponsor, and then the payer and the state and the national level, because school-based health centers are kind of organized in a variety of ways. And so we'll be looking forward to getting that feedback when we're ready to kind of vet that in a larger community, get that feedback from you. And then we also have been working on creating a comparison grid of the national standards of quality measures that are required between CHIPRA and HEDIS and meaningful use. There are a lot of quality standards, but not all of them are relevant to the students that we serve. And so really trying to create this grid of what's out there and how, depending on what kind of opportunity track you have in your clinic, how that's relevant, how you want to tie that in to, whether that's we're looking at purchasing an EMR, what's relevant, what's sort of best practices, because a lot of the discussion really talks about adults. So we want to be able to push that information out that's relevant to all of you. So the great migration from ICD-9 to ICD-10. How do we really get from point A to point B? I don't know. Like I say that, I often tell people, they've been talking about ICD-10, I think almost as long as I've been alive. Because when people, the lucky people who got to go to Geneva, in 1975, people, it's like an iterative process, it's like right once they put that thing down and they're like, but we forgot this and we forgot that. And, and it sort of kind of similar to the DSM-4, where I think, once they put the DSM-4 out, they were like, you know what? And people started arguing as though they hadn't been part of the process to get the DSM-4 together. So it's been almost, I think, equally as long, the DSM-4 and ICD-9, of this process of getting people on board and ready for change and having all of this input. And so, I left off all the small wars and casualties that happened along the way, and then just put a stopping point there about, hopefully you've got together with your version 5010 standards, that should be in place. There was sort of a grace period, but that grace period ends in a couple of days, June 30th. So the CMS Office of eHealth Standards are going to begin enforcing the 5010 transition June 30th. So, and then, I put the whole slash date of, is it going to be 2013 or 2014? But either way, we know that it's an iterative process, and the arrow keeps going. So in a sense, even when they decide here is the end and this is going to be the launch date, I can put money down that, the next day there's going to be a change. So you just have to be ready and flexible. So I'm sort of here really talk about, from our perspective, we really wanted to capitalize on this opportunity of school-based health centers are getting all this, attention, and we got the capital grant, and isn't that exciting? And everyone's sort of looking at how can these clinics fit into this kind of larger landscape of how's it, medical home and accountable care. And we thought that it's a great time, since everyone's practicing being flexible and learning new things, to take this opportunity to talk about the data collection and how, when you're purchasing these things or you're thinking about, you're already changing your workflow. So why don't we take this opportunity to change your workflow to capture this data collection? I said this earlier in a different audience about, we need to tell our story differently. We often tell these anecdotes, right? And so we go to our legislator, we go to the principal, and we say, but Johnny came into our office and he was in foster care, and because he was in foster care, he had all these problems, but because we saw him 10 times and provided him these services, now Johnny actually attends school more often, and oh, by the way, that his mental health is better, and all of these things. That we tell these stories, in an anecdote of one. And the opportunity that the B codes have with the Z codes is that you can actually quantify Johnny's story, right? So there are codes for foster care, there are codes for, my parent has been deployed, there are codes for all of these things. So within your clinic, generally sort of what are these social determinants of health that are impacting your students' lives. And so you can sort of, take that subset and you can code for these things. So you don't have to tell these anecdotes of one. You can then go back and data mine, and you can tell Johnny's story, but then say, by the way, Johnny actually represents 30 or 50 or, however many kids that we see, and Medicaid doesn't pay for that. Cigna doesn't pay for that. Oh, so by the way, this is why, you should give us some money so that we can help Johnny, right? So these are things that we want you to sort of think about in terms of this migration. And then also with the quality improvements, once you're sort of capturing this data, then you can, keep track of it and sort of see, not only are you having these frequency issues, which in the previous session, sort of are important. You need X amount of visits to stay sort of solvent. But it's not just about, I used to run a Title 10 clinic, and it's like, great, I'm happy that I saw 50 kids and gave them Zithromax and treated their chlamydia. How about I saw fewer for the chlamydia problem? Like, what is, I'd rather bill or not bill for my education, my health education, and sort of change their behavior. I'm happy to be here and give them the services that they need, but is that really great in the end for what's going on for them as a person and at a population level? So we want, you can be able to track these things. And then in terms of policy changes that I just talked about, you can take all of these sort of data elements, and you can go to your legislator, you can go to the Medicaid office. I used to work as a health plan manager for CHIP, and people would come, the advocates would come, and having that data is important in order to say, yes, okay, we can pay for these services, or, we need to see more in order for us to pay for these services. So it's helpful in all of those contexts. And then, you can still tweet. Data collection and billing can help, SBHCs tell their story more effectively. So, and I've talked about this, this crosswalk, but then, we are creating the sort of daunting task. I had a conversation with Theresa about how I was going blind doing the crosswalk between ICD 9 and ICD 10. We wanted, to have this thing, but, things change and it takes a lot of time. But what we're trying to do with the SBHC data set is to sort of provide at least a launching pad for you to create. We'll have the data set. It'll be in ICD-10 codes so that we can push this out into the field and you can at least have something to start from to then move forward with to cater, to your clinic. So we want to kind of be a little bit more specific in terms of the story that we're telling and kind of give you an idea about how that story kind of correlates to the codes themselves. So here we have Johnny, my favorite example, student. He's been diagnosed with asthma and he's been having acute episodes. And he visits the clinic and he receives his education and medication administration. They give him a new inhaler and his insurer is Medicaid. And this is a true story, by the way.
Okay, here you can see there's a slight difference in the wording between ICD-9 and ICD-10, but you can see more of the code changes. It goes from 493.02 to J45.21. That's where the alpha numeric codes come into play.
Okay, so then Johnny still has problems. His acute episodes increase. He comes back to the clinic. His family did fill the prescription. It was $50. The NP, watches Johnny practice using his inhaler to make sure, is Johnny actually using his inhaler correctly? Like, what is really the problem? So they decide that the medications are reviewed, they've deemed appropriate, we're all set there. And then we learn through additional history taking that, many of his family members also have asthma. And so they don't have insurance, and so for the adults, the usual source of care is to go to the emergency department, to go to the ER. So everybody's been using Johnny's inhaler. And why Johnny has problems. So,
Again, here, the changing in the wording for the diagnosis code, but you can also see where you can start coding the social impact, that it's having. You have the low income and the chronic family history. It's all important information for tracking purposes.
okay, and we've got our second example. So Lizzie comes down to our clinic and she's feeling down. She sees the licensed social worker, and it turns out, her father was deployed. He's in the reserves recently. So she's reporting restless sleep since her father was deployed.
See, when you use the V codes and the Z codes with the ICD-10, you're telling the complete story. You're telling, you're keeping track and getting the data of the social impact that these conditions are having on. And then you can also track the change that these, the services that you're providing, the impact that you're making on these families, these children. So you don't want to overlook using the V codes and the Z codes. They really are going to be what you're going to refer back to as far as extracting data.
So then it's our little tweetable.
Let's go back to the slide for just a moment. Okay. Social determinants of health can be tracked using...
This mic, I just want to adjust it really quickly. I'm sorry.
Sure.
There's a buzz that's coming over. Let's see if we can improve it all. I'll do a little bit later. Sorry about that.
Okay, so social determinants of health can be tracked using billing codes. And this is a powerful data collection method. that can drive change. Probably a better way of explaining this is, say you created an asthma group or an asthma prevention program, and you identified students in the late elementary, early middle school age. Through billing, you can track the progress those students are having before and after the preventative education was given. More information that you can extract from that is the impact that you have on behavior changes. And again, you can also, another piece of information is money driven, is the cost of treating that person. You can track that by how many visits they had for asthma before the preventative education as to how many visits they're having after the preventative education. And with the significant drop, obviously the cost of caring for that child has dropped also. Another benefit of gathering the information through billing is using that data to advocate for funding. A lot of the legislators they listen more if you have data to back up the impact that you're having on their communities. They're going to be more willing to meet with you and discuss change, discuss more funding. So in Connecticut, as you see, we did do that. We had the data, we kept the data and extracted it and used it to our advantage. So to recap, billing is a great way to increase your revenue, to increase reimbursements. It does provide concrete data to the state and federal government that could result in an increase in funding. But billing doesn't just get you money. Billing is also an effective tool in establishing your results-based accountability, your RBA, which is basically data-driven outcomes that show the impact of your services. So if you're billing, that's great, keep it up. Maybe you might want to change and think about using more of the V and Z codes to fully tell your story. And if you're not billing, maybe after this presentation you're going to think about billing and think about the benefits that you can generate to your health centers through billing.
And I know we just got a few more minutes, but I want to pop back and put you on the spot because Deb actually, she was the one who went and testified and did that. So I didn't know if you wanted to tell more of this story to make it, a real live experience for people and that we're not just talking.
I'll do this. In Connecticut, we had found that we were looking at a volatile situation in our funding base. And it was constantly coming up that we were looking at funding cuts to our school-based health center program. So what we did was we gathered data from the 76 school-based health centers that we had throughout Connecticut and through a SurveyMonkey, and actually ascertained the cost of and created a cost-based analysis based on the number of visits seen through the school-based health centers versus the cost of the emergency room visit. When we went to the legislature, what we did was we actually then stated, we said, do you understand that coming to the school-based health center, which is an educationally comprehensive way to address healthcare issues based on prevention, we're actually teaching kids how to identify their triggers, how to prevent future issues, and it's costing us $22 a visit. We can see those kids for up to 12 to 14 visits versus the one ED visit that is maybe very accessible for them, but
that's actually the difference in the cost. So if they come to the school-based health center and you invest in the school-based health centers, the cost to the system decreases substantially. So Medicaid, our statewide system, whatever you call it, we called it Husky in Connecticut. Now it's called Husky Care. But Husky Care, the cost to the Husky Care program was substantially higher for utilization for the number of kids going to the emergency room for ED visits for asthma-related care versus coming to us. And then we were able, through our longitudinal data, to track these kids and find that due to the fact that they came in for our preventive counseling and education, they weren't actually even coming in for as many visits. So the initial number of visits they were coming in for slowly petered off. They increased their behavior changes and their identification and were much healthier in the end.
Thank you. Okay, in terms of quality measures, we've sort of discussed this sort of throughout in terms of quality has been raised to the forefront due to high health costs. I think that that's a really great example in talking about the quality of the services that you're providing, and that payers are making us report quality measures as a requirement. So if it's part of CHIPRA and you've got all of these options, but you get to choose, you're still having to do this. And then, some are considering how to tie payment to quality, which we discussed earlier and in the previous session also. And, tying meaningful use in potential incentive payment, that goes directly to the providers in your school-based health center. So putting it all, together, which again, I think that we've sort of talked about the importance of, tying these things that in some, depending on how you're structured and the staff, a lot of these things are sort of siloed in terms of, who's doing your billing, and you might, pay other people to do the billing, or your hospital might do your billing, so you don't even know what's going on, and, so you might have somebody in-house who's doing your sort of data mining and your reporting and the quality measures. So tying it all together, you really need to institutionalize some sort of process across all the systems that'll help increase, your reimbursement opportunities, your tracking of, these important data elements, and reporting just data in general. And as we've discussed, that this information really demonstrates the reasons for school-based health centers to exist. And it quantifies what that you're already doing, so that you're not stuck on just providing these anecdotal, sessions or, stories. And it really can improve your advocacy and the policy work. And all of this is really just so that you're doing this work. We want you to stay open. And we also think that this is a really, really important model. And in order for it to really scale, I think that we need to provide these data elements so that we can go into other communities and sort of show the relevance, across our state, across the, the countries. So here's our little tweetable moment about how we're going to be building sustainability, one CPT code at a time. And I think we've got time to crowdsource solutions. Yeah?
7 minutes.
7 minutes to crowdsource some solutions. So we wanted to have a little bit of a discussion about what prevents you from integrating clinical and demographic data factors that influence, health status. And, have you used data, to tell your story that led to an outcome, like one that we've heard here from Connecticut? And how do you use data to sort of improve your quality? Anybody have any stories, or anybody have any barriers, and they're sort of looking to the people in the audience today to help them with a problem? Because I know that some of the feedback that we get is that, you don't get, we won't get paid for the Z codes or the B codes, so what's the importance, why should we do that? Or, they don't want to deal with it being kicked back. They haven't even tried to see if it gets kicked back, but they don't even want to go down that path since they're pretty sure they're not going to get paid. And so, there are a variety of ways that you can get around it, and you can try it and see if you get kicked back, because you might not. Maybe they do pay it and you've never tried. Or, it's still, and if it doesn't get kicked back, then that's great, because then it's in one whole system. So you can still code and do all that coding and put that in the process, and then you've just got one place to sort of data mine, as opposed to which some places do sort of create, because they're tracking it for quality measures for other reasons, that they, will sort of double document so that they keep track of these codes in a separate place, to sort of double work, but at least they still have the information that they can go to and then get that information back for their purposes.
Just one more point about the data collection, that as we're moving toward PCMH, we're not sure how that's going to unfold down the road, but for everybody I would actually also encourage, the V codes are going to tell the story of the case management care coordination that we do. That's going to support us as we move forward in actually looking to involve ourselves in PCMH. So it's also, it seems like a pain sometimes to think about it, but since we're all moving that direction, we're all doing the care coordination anyways, we're not getting paid for it, but if we make the case for as much as we're doing and improved outcomes, I think we do have a case for a foundation for inclusion.
And I would also say that, in the previous session, they talked about all the different organizations that are providing that patient-centered medical home certification process. And what we're finding at NASBHC is that, some regions are very responsive, and some regions are not. And so, a lot of people, you've got a huge organization, they might not really understand what school-based health centers do and how what we do is actually relevant to a medical home. And so it's really important to, bring them in if you're in that process, because they might from the beginning just say, no, it's not worth it. Or if you're part, we've also heard, from plenty of clinics where, their FQHC is sort of going along the certification process, but even though they sponsor school-based health centers, they still don't really see how the school-based health center feeds into the concept of medical home, and so they don't want to pay for the process. And so they're getting left out. And so this is a way that you can go to your own sponsor who you think is already on your side to say, hey, we're doing these things, and it's not because I'm telling you the story. We're really doing these things. I have it quantified because I'm telling you that has been a problem, and so that could be really helpful for you.
Do we have any other comments, questions, or suggestions from our audience? You're all so shy. I think it's because you're on camera. So, okay.
Look for the app.
Look
Yes.
Those V codes, that would be awesome.
Definitely. Well, I just wanted to tell a quick story about Michigan. About 10 years ago, our organization was just a grassroots coalition of all the school-based health centers in the state of Michigan. And our governor, in an executive order, eliminated all the funding for our school-based health centers. All of our funding. So fortunately, we had a coalition of folks, and Kate in the back was one of our leaders, and she and others rallied the troops. We had a wonderful rally at the state capitol. We sent letters, had phone calls, had kids come up and protest. I mean, it was just everything you could possibly imagine in terms of grassroots mobilization. We had great champions in the legislature on both sides of the aisle, Republicans and Democrats. And they said, we will restore your funding. We will make sure this happens. But we have a condition. You have to bill. You have to bill Medicaid, and you have to get to a place where you can bill, other commercial insurance. So, Kate, do you want to add something? Because Kate was a witness and involved in all of that.
I was actually going to bring this up. I wanted to just say we learned the hard way.
Right.
That we didn't have the data to prove that this was worth the state investing in. And so we we had years and years of service, and we had numbers of kids served, but we didn't have any of the hard data of any kind of, quality measures or any improvement or measures or outcomes or anything. And so we kind of learned the hard way, and that's why we went very aggressively, in great deal with the help of the Kellogg Foundation and Terry. But we had to learn our lesson the hard way.
And it was a blessing in disguise.
It was a blessing in disguise.
On so many levels. But related to the billing, it made us, we had to formalize what we were doing in Michigan. So we established our own 501c3, and we worked with the Kellogg Foundation to establish the beginnings of a billing network that supported the network of school-based health centers in the state of Michigan. And today, our organization actually does billing for 7 of our fiduciary organizations, which includes about 34 of our 70 state-funded school-based health centers. And as a result of that, we are able to provide all the data that all those folks need to comply with our state data and reporting performance standards. So we have some very, standard reporting that we generate for the state and for ourselves. We've been able to design our training more effectively for our providers and for our medical assistants and billing and coding people, and et cetera. We've also been able to use it to advocate to maintain our funding again. We suffered another cut, but we did not lose it all because we had, then almost 7 years of data to be able to justify why we needed to continue to receive state funding. We've also been fortunate in figuring out how to Medicaid match our state funding. So that's another leveraging point that we can talk about on another day. But all of these things, every one of these examples that Joy and Theresa have shared with you, we've lived and breathed in the state of Michigan. And I'm sure if you stopped and talked with your colleagues at the state associations around the country, you would hear similar stories. So I know it might be a little stressful in the next few years. It certainly hasn't been unstressful in the last 2 years as we've been starting to implement EHR. But obviously there's a tremendous benefit at the back end. I mean, our end game is to better serve children and youth. Our end game is to improve their health outcomes. And we in school-based health centers are a vehicle to do that. And we need to be able to document why and how we are doing that. So I challenge you to, keep fighting the good fight related to all of this and tell you that together with NASBHC, we will continue to share all of the best practices and lessons that we are learning with this Kresge project. Terry Wright, who's in the back, is contracting with us to do another aspect of the project where she's analyzing education, health, and social determinant data resources around the country, and we'll be putting together a compendium of those lessons learned, and we'll share those with you next summer at the NASBHC conference. So stay tuned and come back often.
All right. Well,
Thank
you
you
so
very
much.
much.
Thank you.